Otosclerosis is a common condition that affects the inner ear in 7 to 10% of Caucasians. The condition is much rarer in non-Caucasians, except for East Indians, in whom the incidence is approximately the same as Caucasians. Because the bone changes of otosclerosis may affect parts of the ear not directly associated with hearing, it causes significant hearing loss in a much smaller number. The condition may even affect this part of the inner ear responsible for balance, causing dizziness. 2/3 of patients treated for otosclerosis are women. 70 to 80% of cases involve both ears. Cochlear otosclerosis is used to describe the nerve hearing loss seen in some patients with otosclerosis. This process can result in profound neurosensory hearing loss that may not be helped by stapedectomy. In the rare cases where both ears are severely deafened, cochlear implantation may be the only option for hearing improvement. Fenestral otosclerosis is the term used to describe the effect of otosclerosis on the stapes or stirrup bone. Otosclerosis causes the stapes to essentially stick to the inner ear instead of moving freely in and out with sound vibrations. The ear contains 3 bones: the malleus or hammer, the ancus or anvil, and stapes or stirrup. These names roughly describe their shape. The bones are connected to each other and to the inner ear with delicate ligaments. In otosclerosis, the ligament around the connection of the stapes to the inner ear, an area called the oval window, may thicken and become replaced with rigid bone, also known as fenestral otosclerosis. With the flexibility of the ligament lost, the stapes cannot move smoothly in the oval window. When this happens, conductive hearing loss occurs. Sound vibrations cannot get into the inner ear. This slide shows how the inner ear near the stapes is affected in early otosclerosis. The blue arrow points to the abnormal bone. The short white arrows point to the ligament around the footplate of the stapes. Although otosclerosis, by involving the inner ear, may affect nerve hearing and balance, this patient probably doesn't know that he has a problem because the stapes is still able to move smoothly. This patient may be getting some idea there is a problem. The white arrow points to the normal ligament of the oval window. The blue arrow points to the ligament affected by otosclerosis. This patient probably has a small degree of conductive hearing loss because the stapes can no longer move perfectly freely. However, the problem may not have reached the point where surgery is recommended. This patient will have more severe conductive hearing loss. The ligament has mostly been replaced with bone. However, the footplate of the stapes remains relatively thin. This patient is probably an excellent candidate for laser stapedotomy. The ligament of this patient's stapes has been replaced by thick bone, and conductive hearing loss may be severe. The laser still may be used to do the operation. These patients will have very severe hearing loss. Because the bone of the stapes is now so thick, the microdrill will almost certainly be required. Otosclerosis, like cataracts, does not demand treatment. However, like cataracts, without treatment, otosclerosis can severely impact a patient's quality of life by depriving her of hearing. Some patients have particularly aggressive otosclerosis that may cause fairly rapid loss of inner ear hearing or rapidly progressive conductive hearing loss. These patients may take a combination of fluoride and calcium called Monocal. Monocal may slow the rapid progress of hearing loss in these cases, but its effect is not reliable or uniform. I typically recommend a single Monocal tablet daily for 6 months for patients who wish to try it. Hearing aids are effective in most patients with hearing loss due to otosclerosis. Relatively rare patients with inner ear damage due to otosclerosis, these are usually patients who have had the condition for a long time, may not get much benefit from hearing aids because their ability to understand speech is so poor. Surgery is an option for many, but not all, patients with otosclerosis. Surgery is usually not recommended for patients with mild fenestral otosclerosis that doesn't cause much conductive hearing loss. In patients with mild otosclerosis, the benefits of surgery may not sufficiently outweigh the risk of the operation. For patients with significant conductive hearing loss due to otosclerosis, Stapes surgery is usually very effective at correcting most or all of the hearing loss due to the fixation of the stapes. For patients who have severe inner hearing loss due to otosclerosis, replacing the stapes may not help sufficiently, and instead cochlear implantation may be recommended.
After elevating the patient's eardrum and protecting the chorda tympani or taste nerve, the tendon of the stapedius muscle is vaporized with a CO2 laser. Next, the posterior crus or leg of the stapes is vaporized with the laser. After this is done, the stapes superstructure is downfractured and then removed. Here, a CO2 laser with a scanning device is used to create a perfectly round 0.6 millimeter hole into which the prosthesis will be placed. In cases with thicker bone, a diamond microdrill may be required. A platinum and titanium piston is placed into the opening made into the inner ear and hooked over the anvil bone. The platinum portion of the piston that is placed over the anvil bone is crimped to secure it to the bone.
Dizziness is normal for a few hours following stapedectomy and may result in nausea and vomiting. Some unsteadiness is common during the first few postoperative days. Dizziness on sudden head motion may persist for several weeks. On rare occasions, dizziness is prolonged. Taste disturbance and mouth dryness are not uncommon for a few weeks following surgery. In 5% of the patients, this disturbance may be prolonged. Further hearing loss develops in 2% of patients due to complications of the healing process. In less than 1%, this hearing loss is severe and may prevent the use of an aid in the operated ear. Possible causes include development of scar tissue, infection, blood vessel spasm, irritation of the inner ear, or a leak of inner ear fluid. For this reason, the poorer hearing ear is usually selected for surgery. In the unlikely event hearing is worse following stapedectomy, tinnitus or head noise likewise may be more pronounced. A hole in the eardrum is an unusual complication. It develops in less than 1% and is usually due to an infection. Fortunately, should this complication occur, the membrane may heal spontaneously. If healing does not occur, surgical repair may be required. An extremely rare complication of stapedectomy is weakness of the face. This usually temporary weakness may occur as the result of an abnormality or swelling of the facial nerve. As in any surgery, infection and bleeding can be complications, although in Stapes surgery, these are very rare complications. For most patients with otosclerosis, the changes of the bone that cause hearing problems eventually stop. Hearing may remain at the same level for the rest of your life. In some patients, the disease progresses. Fortunately, patients with otosclerosis very seldom go totally deaf, but will be able to hear with an electronic aid. The older the patient, the less the tendency for further hearing loss due to the otosclerosis process. There is some evidence that unoperated ears with otosclerosis may lose hearing sooner than an ear that has surgery. This is based on studies of patients who have otosclerosis in both ears, but who undergo surgery on one ear only. Stapedectomy or stapedotomy is performed under local anesthesia with sedation or general anesthesia. I recommend general anesthesia for patients who are very anxious, markedly overweight, have sleep apnea, or tend to snore loudly, since under sedation these patients may move, making the microscopic surgery more challenging. Patients who have local anesthesia with sedation usually have a faster recovery with less risk of nausea. All of the work on the stapes bone itself is done through the ear canal. A tiny incision is usually made behind the ear to remove tissue for use during the operation. Stapes surgery is usually done on an outpatient basis. Occasionally, the person is admitted overnight. Patients should not plan to drive a car home from the hospital. However, automobile travel with another driver is permitted immediately. After surgery, go home and rest. Sleep with your head elevated on 2 to 3 pillows to reduce swelling inside the operated ear and pressure in the inner ear. Hearing improvement may or may not be noticeable at surgery. If the hearing improves at the time of surgery, it usually diminishes in a few hours due to bruising in the ear. Improvement in hearing may be apparent within 3 weeks of surgery. Maximum hearing improvement, however, is obtained in approximately 4 months. During this healing time, it is normal to hear popping and bubbling sounds in the ear, especially when yawning, chewing, or swallowing. This is air entering the ear through the eustachian tube. The degree of hearing improvement depends on how the ear heals. In the majority of patients, the ear heals perfectly and hearing improvement is anticipated. In 1 to 2% of patients, the hearing improvement is only partial or temporary. In these cases, the ear usually may be reoperated upon with a good chance of success. Although the ear is a very sensitive area, pain after the Stapes surgery tends to be mild and very short-term. Usually narcotic pain medication is required for only 24 to 48 hours after the surgery. Patients may return to work in 3 to 7 days after surgery, depending on the occupational requirements. Patients must avoid lifting more than 15 to 20 pounds for 3 weeks after surgery to allow the inner ear to seal. Patients employed in heavy manual labor may require 2 to 3 weeks off work. You should not get water in your ear until I have confirmed your ear canal incision is healed. Remove the Band-Aid behind your ear the day after surgery. You may wash your hair and the small incision on the back of your ear as early as 3 days after surgery, but keep water out of your ear when showering using a cotton ball and some Vaseline or antibiotic ointment. Do not blow your nose or sneeze with your mouth closed for 3 weeks after surgery. If you must sneeze, open your mouth. Do not use cotton swabs in your ear. Air travel is permissible 3 weeks following surgery. You return to our office for a postoperative visit 1 to 2 weeks after the operation. If you have severe dizziness or vertigo, which is the illusion of spinning, you should call. While some ringing in the ear is common in the early healing period, please call if the ringing becomes much louder. Pain normally subsides in the early postoperative period. If your pain is increasing, you should call. Some oozing of blood from the ear canal is normal. You do not need to worry if bleeding does not saturate a cotton ball over a 24-hour period. Call if there is excessive bleeding. Call at once if you think you have an infection. Creamy and or smelly discharge, along with increasing pain and swelling, are the signs of this unusual complication.